This is actually a very common case, but it was just a lot, very challenging. So a 70-year-old male with severe aortic stenosis, functional class 4 dyspnea on exertion, and CHF. His comorbidities included coronary disease, status post-CABG in 2002. He had a patent limb out of the LED, a saphenous vein graft of the RCA, and a saphenous vein graft of the OM. Ascending aortic aneurysm, size of which was 5 centimeters, COPD, hypertension, hyperlipidemia. His STS turns out to be just 4 if you just take into account aortic valve replacement. But if you took into account his prior CABG, and if you take into account that he needed an aortic root repair, that increased the mortality. So none of the local surgeons in our hospital, all the local surgeons wanted to operate on him. So he was sent over to me for consideration of TAVR. Look at his echo. His echo is a bicuspid aortic valve. It was a type 0 with orientation of the free edges of the cusp being anterior and posterior. The valve area was 0.7, mean gain of 57, peak gain of 100, and EF of 65. The CTA data showed the maximum ascending aortic diameter of 5 centimeters, sinus of valsalva width of 60 millimeters, sinus height of 43.8, STJ width 40.9. And the annulus, these are measurements of the annulus, 23.6 times 26.4 millimeters, perimeter 80.3, area 499.7 millimeters square. So this is just a representative image, CT image showing the bicuspid valve, the third one, the lower left one showing the bicuspid C0 type. These are the images showing heavily calcified aortic valve and the bicuspid nature. We looked at the transfemoral axis, everything looked good, both sides were feasible. And we thought it was going to be a routine case, a routine bicuspid case. Before I went into the case, I didn't appreciate the tortuosity. If you look here, I picked the right femoral. The right actually goes to the left, and then it again makes another turn to the right, and then starts making another turn to the left, and then takes this, another curve like a roller coaster coming down on the calcified aortic valve. This is again showing just the tortuosities in the aorta there. So start off in standard fashion, got a pigtail and non-coronary cusp. I took a root picture, which basically just showed the severely calcified valve. I crossed again standard fashion with a straight wire, but once I crossed, I was unable to advance an AL1, or for that matter, any catheter across the valve, even one of a very small crossing profile. The problem seemed to be a combination of the severely calcified small aortic valve opening with a dilated and horizontal aorta, which prohibited good backup for our pushing maneuvers. So, at this point, I had my AL1, which was, I just had the tip of the AL1 across the valve, and I said, I'm not able to get it across. Let me just put a stiffer wire. Maybe that's going to change it. So I somehow stuffed this safari wire in. That's not the best thing to do, but I pushed it in and got that. But that didn't change anything. And then I actually, at some point, switched to Lundquist, and this is what was happening. So each time I pushed anything, you can see, when I push, it all goes down in the sinus. I'm pushing the sinus. The forces are all, they're not into the valve, and my wire just keeps prolapsing out of the LV. So in order to overcome this challenge, I thought maybe, putting a second stiff wire into the LV and using maybe an option. So I tried that, but I couldn't cross. I couldn't I couldn't cross with this with one wire in the LV. So I said, okay, let's just switch out. Try this. Recross again. Maybe there's a different channel we can go through. Didn't help either. So I said, okay, let's leave a buddy wire with a second pigtail, just in the cusp, and see if that straightens it out. But it was same result. Everything kept prolapsing out. So at this point, I was unable to advance valvoplasty balloon across the valve, despite using, whatever techniques you know of, also using the stiff Lundquist wire. As a last resort, I decided that I'd use a 10 by 40 Mustang peripheral angioplasty balloon, which I'd advance with great difficulty, despite its small profile, as you all know. And I performed balloon valvoplasty. So this is the This is the Mustang balloon going up. You can see there's a clear waste there. It looked more like I was doing a coronary, I was actually doing a pre-dilatation of coronary artery. So once I did the dilatation of the Mustang, I proceeded with do valvoplasty with a tie shack balloon. And somehow got the tie shack in, but the 20 millimeter tie shack ruptured. The amount of the calcification was so much that it ruptured. So then got a 24 millimeter tie shack, inflated that, and at this point I thought I had a good result, and I was going to be, I thought everything was going to go fine after this. So, but despite adequate valvoplasty, prolonged maneuvers with the guide wire, it was not possible to advance the core valve prosthesis across the native aortic valve. Extremely heavy calcification on native valve, unfavorable aortic angulation, small LV cavity, dilated aorta, and aortic tortuosity caused the system to hang up on the aortic wall. So this is what you can see. So I have the core valve there, but this is where the valve is. And my valve doesn't want to advance further than this, because each time I push, I'm either pushing it up, pushing sideways, upwards, and I'm just pushing the wall. And my Y keeps flopping out. And this is just showing you the tortuosities which didn't straighten out with the Lundequist. And again, these are the angulations I'm facing when I'm doing this. So, but at the end, after all the balloon valvoplasty, I was able to put a pigtail in, which was the first time I was able to get a catheter into the LV. So once I had that, I started looking at what my options were. Said, okay, maybe a subclavian axis. But looking at this, then I looked. So I said, maybe you switch to a subclavian axis. But I didn't think that I was going to get, changing to a left or right subclavian would provide any addition to ability to force or push the core valve. A direct transaortic approach would definitely be better. It means general anesthesia and added surgical invasiveness. So, at that point, I opted to switch out and say, let's try. I think the Edwards switch to the Edwards Sapien platform, use the flexibility option of the Commander delivery system. In my lab, we don't have flexibility of just switching valves from the core valve to Edwards. You need the rep-in, so I had to stop the case, bring the patient in 2 weeks. So I brought him back in 2 weeks. Again, same difficulty, but I was somehow able to use the delivery system of the Edwards valve and get this across. It was tough, but we were able to get it across, and then we went ahead and, then standard fashion deployed the valve. It does come out a little bit, but it looks, other images which show that it was. So at the end, we had some, we had some mild PVL. Looked at the echoes; they were just mild, never the moderate range, so we left them alone. So, I've seen him fall up in 3 months. He's been doing good. So, inability to cross the stenotic aortic valve with a valvoplasty balloon in the setting of transfemoral TAVI, although extremely rare, leads to immediate procedural failure and or change to a more aggressive approach. The menu was described in our case. It's use of a stiff wire, use of peripheral arterial balloon, serial dilation, and switching delivery platforms can provide solution to this rare hindrance. Yeah. Thank you.
Quick question. I saw that you're having trouble. Obviously, it looks like a horizontal deployment. It's obviously tortuous there. Did you put a 20 French long sheath in to deliver the core valve in, or did you go inline only?
No. We had the sheath in. As soon as I saw the tortuosity, I decided this was not an inline case, because I put a sheath in, and even with the sheath in, it was, and I actually lost access. I mean, inside, it was just flopping out of the LV each time you try to do anything.
Yeah, it looks like you couldn't even get your nose cone on the valve, right?
No, nothing. I mean, the nose cone was just hitting the wall, and each time push was just going to the sinus. The sinus was so big. At the end of the case, I usually always, after I finish my case, I do a completion, I look at the hemodynamics. Each time I tried, I couldn't get anything through that valve. Each time I just wanted to go into the sinus.
No.
That's how big the sinus was.
We use both valve platforms in our lab, and intuitively, I feel like the Medtronic valve tracks better. But for patients with like 3-dimensional aortic tortuosity up in the arch, I feel like you're fighting yourself with different forces in different directions. Once you make one curve, then you're biasing the other way. So we've switched completely for this type of situation. We would go straight with over 10, given a few experiences like this.
Yeah, and
Do you guys feel transaxillary would have been more advantageous than going?
Yeah.
Because you're just avoiding, I know what you're saying, Ganesh, but not being able to,
the horizontal route was what
It's a shorter, especially if it's conscious sedation, you don't want to convert at that point.
Yeah. I mean, I think the Edwards, if I start off with Edwards, I'm not sure if I would be able, because I couldn't get a balloon initially. But I think once you got the balloon in, the Edwards was the way to go.
Absolutely. I think the serial balloon inflation starting really small was a very smart way to go.
So did you try Innova wire? That might have helped you deliver it better.
The Innova, I think it's pretty similar to the Safari wire.
Safari.
Yeah, the Safari wasn't giving me enough support there, and I had the Lundaquist after that. Even that wasn't giving any support there. The wire would just flop out of because the forces were such that when you were pushing to the side, and then you were pushing up into the arch, and then the other one was, the side of the sinus.
So the Safari wire you can deep seat it quite a bit so that you have the stiffer portion in that.
I can show you some images where the wire is deep-seated, and we looked at that. We looked on echo, I measured in the apex, but you push, everything just comes out. It's like there's just no support there.